Good afternoon, everyone, and thank you for joining us today, and welcome to the CBHN Health4Life Series. I am Rhonda Smith, the Executive Director of the California Black Health Network, and we are heading down the home stretch in our series on Let's Dismantle Diabetes. So today is session number 4. That is focused on diabetes equity and access and why where you live matters. So we'll specifically talk about the social determinants of health and understanding how the social determinants of health and why your zip code really matters and how it impacts your health potentially, how the type of insurance you have may play a role in access to treatment and resources you may need to manage your diabetes, and then what you can do about it. And so once again, we have with us Dr. Courtney Walker, who's the Health Equity Outcomes Director at Novo Nordisk. Just as per usual, before we start the program today, just a few housekeeping items. So we will hear from Courtney, who will first share a short presentation on the topic for today. And again, the chat box will be open if you want to give a shout out to someone, make some comments, add your commentary, but please try to put all your questions in the Q&A box at any time during the session. Again, everyone will remain on mute and off video or off camera for the session. So before I introduce Dr. Walker, I just want to share a few words or information about CBHN in the event that some of you on the call today or the session today may not be aware of who we are and what we do. And so our vision is to create a California where every African-American and Black immigrant has the opportunity to live a long, healthy life that's free from violence, racism, and health inequities. And we work to do that every day by ensuring that all Black Californians, regardless of how well educated they are, how much money they make, where they live, how they identify or who they love, and even where they're from and their housing status, has an opportunity to have access to high quality, equitable, primary as well as behavioral health care, and definitely not succumb to diseases that are preventable and that we shouldn't be dying from. And so I just want to move it along so that we can hear all that Courtney has to share today. And so once again, I'll introduce him just to give a little bit of background and information on the speaker for today. Dr. Courtney Walker, again, is the Health Outcomes Director at Novo Nordisk. In this role, he serves as a subject matter expert and primary point of contact for external health equity champions with the managed market accounts. He was previously the medical account director at Novo Nordisk for the Texas, Arizona, New Mexico, and Las Vegas region, specializing in diabetes and obesity. Dr. Walker has spent his time consulting on health plans at the state government and with state government organizations, mainly around Medicare, MediCaid. And in that, he's been responsible for working with those organizations for drug formulary decisions impacting millions of patients throughout the country. Dr. Walker is a proud graduate of TSU, Texas Southern University's College of Pharmacy and Health Sciences in Houston, Texas. Upon completion of his doctorate of pharmacy degree, he completed a managed care pharmacy practice residency at Humana in Louisville, Kentucky, and at the University of Kentucky's College of Pharmacy in Lexington, Kentucky. And so without further ado, I'll turn it over to Dr. Walker, and it's all yours. We look forward to hearing
Thank you so much, Rhonda, for that introduction. I'm going to open my slides up now. And Rhonda, I didn't tell you, but my wife and I had a wonderful time in San Francisco this weekend eating. So we got to experience the great California cuisine there.
Well, you have to share some of your notes. You have to share some of your notes with me.
I will. I will definitely do that. Okay. Can you guys see up my slides now?
Yes, we can.
Excellent. Okay, well, we'll go ahead and get started. And thank you again so much to the California Black Health Network for this opportunity to talk about dismantling diabetes. This has been a joy, and actually I think it's a model for conversations that we can have across cultures, across different groups, where we're really now working to identify why we're in the situation that we're in from a health standpoint. And I think that, you know, today's session, the last session where we talked about treatment was a joy. It was great to have that conversation. But I think today is going to be a very interesting and strategic conversation, because we're going to talk about equity and access, why where you live matters. And in this session 4, we're going to really just kind of talk surface about that. But I'd love to hear, when we're done, I really want to hear your questions and hear the questions from those who are watching and some of the comments, because I think it's going to take all of us to basically create solutions so that we have a better future in regards to African Americans and diabetes, and how we can work to see better health in the African American population specifically, and it'll probably stretch out to others as well. Again, why does this matter? Why are we talking about this? In 2019 in the United States, again, we estimated 37.3 million people had diabetes. 96 million people age 18 or older had prediabetes. So remember, as we've talked about before, prediabetes is you're on the runway, okay? You're not in the air yet, but you're on the runway headed towards full-blown diabetes diagnosis. We've talked about what the numbers are, how screening, how that's measured, how that happens. Specifically in the African American population, we know that the prevalence of diagnosed diabetes by race and ethnicity in the United States, African Americans represent 12.1%. Okay, that's going to be second in terms of the people groups. Right after Hispanic population, we're going to see 12.1% of a prevalence in the adult population, which is significant. And I shared this quote beforehand, and I'm going to share it again. We know that a child's life expectancy is predicted more by her zip code than her genetic code. This information came out in 2022, and this has been as of last year. And this is a conversation that has been had recently to really speak to the fact that it's no longer genetics, but it's where you live. And it's really about access to resources. And it goes back to when I shared with you guys W.E.B. Du Bois' book, The Philadelphia Negro, where he talked about the research that he did in Philadelphia, where he did a sociological study of African Americans in the city who were considered to be in the more dilapidated area of the city. And it wasn't about the inferior health was thought to be because they were inferior, but it was not due to inferiority. It was due to and the shorter lifespans that were noticed were due to the places they lived, the food they had access to, and their education. And so that's why this is such an important conversation. When we talk about where you live and why it matters, really speaks to the resources, which goes back to the quote that I shared earlier with you guys that I had in an earlier presentation, when I talked about when a flower doesn't bloom, you fix the environment in which it grows, not the flower. And what we know is a flower is impacted by the soil it has, by its sunlight amount. It's impacted by the soil, the sunlight. It's also impacted by its ability to have the carbon dioxide oxygen exchange. All of those resources play a significant role in the plant being able to flourish and grow. And the same thing is true for a person, because what we talked about was the individual is the sum total of all these parts, right? So the individual has interpersonal attributes, which comes from family and values and ultimately culture. Then organizational. What are some of the organizational contributions to the person? Their faith organizations, their churches, their schools, their community organizations. And then in the community, their access to parks and recreation, their neighborhood, the food industry, what types of foods that they have access to, the quality of foods, and then public policy that's overarching, where government laws, regulations, and then the media squeezes between the community and public policy. All of these things play a role. And so everything goes back into the individual. So when we think about why we have the problems that we have in the community and why diabetes is such an issue, it really is appropriate and necessary for us to evaluate the interpersonal, the organizational, the community, and ultimately the public policies that really have contributed to the African American population struggle with diabetes, and specifically in California, evaluating different cities and states and how those contributions certainly affect the African American community there as well. And then again, when we talk about the intersection of health equity, social determinants of health, and health disparities, the health equity is the goal. It's about removing barriers to ensure everybody reaches their full health potential. What is it? And I love, again, every time I get an opportunity to talk about the difference between equality and equity. Equality is everybody gets to go to the game, but it doesn't take in consideration, does everybody have the same opportunity to see the field and experience all the benefits of the game? They get to see it equally. But equity says we're going to make sure that everybody has the ability to see equally the game and reach their full health potential. And it really, and certainly the work has to be done by the individuals to see the game, right? And so that's what we have to talk about, within our culture, making sure, we'll get into prevention more so next week, where, hey, how can we make sure that we don't bring the horse to the trough and the horse doesn't drink, but the horse comes to the trough and drinks? And meaning, from a cultural standpoint, we do everything that we can do to be as healthy as possible. Okay, so the approach to reach the goal of health equity is evaluating what are the applicable social determinants of health. Is it education? Is it healthcare and quality? Is it neighborhood or environmental issues? Is it social or community context? Is it economic in origin in terms of the issue? And then how do we measure effectiveness? It's about evaluating, is disease getting better or worse? Is our obesity rates from a racial standpoint getting better or worse? Is diabetes getting better or worse? And that's what we have to evaluate. Because again, when we look at the social determinants of health and how it relates, did you know that when you look at that individual person, only 20% of their health is based on their access to quality of care, their direct patient care? That's only 20%. But the other 80% are going to be the social determinants of health, 40% being social economic factors, education, employment, family social support, income, community safety, 10% the physical environment, and then 30% having to do with health behaviors that you have direct you have the ability to control it yourselves. We have the ability to do something about it ourselves. It's not something that's beyond our control. Tobacco use, making the decision to use tobacco or not, diet and exercise, eating better, exercising, alcohol, deciding whether or not alcohol use, and then sexual behavior and that impact on health as well. So when we think about why this is important, again, it goes into these metabolic risk factors associated with type 2 diabetes. What we know now is that type 2 diabetes is connected to inflammation, oxidative stress, prothrombotic state, endothelial dysfunction, insulin resistance, triglycerides being higher, lower HDLs, which contributes to cardiovascular disease, hyperglycemia, abdominal adiposity, which means visceral fat growing, larger stomach areas, lipotoxicity, and then high blood pressure. All of these things are connected to type 2 diabetes if we don't treat. So think about it, going back to the zip codes, going back to our communities. So think about these zip codes. Inner city zip codes where there's a lack of resources, individuals living there, eating poor quality foods, leading to type 2 diabetes, untreated diabetes, because again, 20% of the contribution to their health is direct patient care. So patient care not being great, disease proliferating, growing, these risk factors getting worse and worse and worse, thus contributing to all these other types of comorbidities. So you're then talking about diabetes and associated costs there, where $34.2 million. And then ultimately $327 billion overall. Annual costs, non-alcoholic fatty liver disease, 98 million. Obesity, 93.3 million for adults, 13.7 million for childhood, and then cardiovascular disease, 121 million. All of these dollars being significantly contributing to the problem and to the burden of cardiometabolic diseases in the US. And so that's why this is so very important. So when we think about racial inequities in medication use, we have to think about the racial inequities specifically when it comes to medications and your ability to get medications. So antidepressants, anticoagulants, diabetes medications, dementia, and drugs and statins for cholesterol. All of these, we see racial health inequities associated with it. And then managed care pharmacy has to do a job of really evaluating the benefit design structure to ensure that African Americans are not in a disadvantaged position. Because what ends up happening is if the benefit designs are shifting costs of expensive medications to patients, that create these affordability crises for lower income workers who are disproportionately sometimes of those of minorities. What ends up happening is, take a look, in 2018, median full-time pay was $916 for whites. But African Americans, it was $694 and $680 for Latin Americans. So when you think about that lower median weekly full-time pay contributing to less likely being able to get the medications that are needed. And this is where this whole concept of, do I get my groceries or do I get my groceries or do I, take care of my insurance? Take care of my medications, in individuals, especially the elderly population, being really hit with those very difficult decisions to be made. And then when you look at rebates, uninsured Americans disproportionately 24.9% Latin Americans, 14.4% African Americans, and 8.6% whites. The average generic prescription in 2018 was $43.67, but the average brand prescription, $105.74. So being able to factor in those costs. And then when you talk about cardiovascular disease, when you talk about kidney disease, when you talk about cholesterol disease, as you age, it is very costly for medications to treat said diseases as you age and as you get older, and you're thinking about earnings potential and the money that you're able to have to be able to take care of those things are huge. So when we think about policy options to improve access to prescription medications, Medicaid is an option, but 1 in 5 people of color have access to prescription drugs through Medicaid. Virginia was recently expanded Medicaid, being the 33rd state to do so. Okay, the Affordable Care Act, which in its promotion, is played a role in increasing health insurance among low-income people of color. But we know prescription drugs are one of 10 essential health benefits the ACA requires insurers to cover. And then value-based formulators, and we're actually seeing now more of these value-based designs to take in consideration ways to cut costs, to use a value-based formulary methods that are now taking in consideration social determinants of health or healthcare disparities in their design. So if there's a drug with similar efficacy that costs less, that drug can be placed on the insurer's formulary in favor of a competitor. So basically coming up with strategies to make sure that as many people can get care as they need. And that's extremely important because health plans now are identifying healthcare disparities and gaps in care by looking specifically at race-specific data when they align it to their HEDIS measures. And these are measures where they are basically held accountable for making sure that their member population has A1C testing, or making sure that high blood pressure is being controlled, or that diabetes care, those with diabetes specifically have their blood pressure controlled, or those individuals who are on statins for high cholesterol, or maintaining a high sense of adherence, or at least at 80%. And so when you look at that from a race specific standpoint and see how the different races are doing, you can identify areas where there's needed improvement. And for example, if you see the pink controlling high blood pressure, you see the African American population represents the lowest in terms of those who are reaching control. So certainly that's an area that needs help. And then from a comprehensive diabetes care, A1C testing, 83.5%, representing the lowest, was African Americans. And this is out of Blue Cross Blue Shield of Massachusetts. It's going to take this type of research to be done so we have an idea of what's happening in the African American population to see how we compare, to make sure that health plans are detailing the African American patient, to make sure that we can dismantle diabetes in a way where we're more accurate in the services that are being provided. So when you take in consideration, cultural issues, because we have to take that in consideration, we've got to be a little bit more specific, more caring in our approach, and taking in consideration ethnicity, racial identity, cultural sensitivity, cultural competence, and humility. All of these things are going to be huge because there's a core health belief and value system, there are attitudes towards treatment, and medication taking behavior leading to adherence that as clinicians, we have to be a part of making sure that we're providing more accurate care. In identifying these barriers, time constraints, financial limitations, access to culturally competent resources, and then looking from a cultural standpoint, language. What are some of the cultural norms and values? What are the stereotypes? What are some of the cultural beliefs and body language that really need to be addressed so that care in the African American community can be better? And how do we then overcome? We need to do that through looking at all forms of discrimination, where unfairly disadvantaging people leads to some of these social and health inequities, and looking for the fact that we have to prepare more for a diverse patient population, understanding biological factors in diabetes influenced by culture. And we've talked a little bit about that through this series, gaining experience with lifestyle and behavioral medicine, motivational interviewing where appropriate, asking the questions to understand the culture, understand the makeup, understanding what's relevant, what's not relevant. That is extremely important. Not so much translation service in the African American community, but social prescribing, wearable technologies, web-based resources, community engagement, and make sure all of these resources are made available so that the African American population can really begin to see improvement. And so, and that's also to identify language differences, making sure the clarity is being, in terms of speaking with clarity and slowly, short key messages, appropriate written communication, understanding language and gestures to understand how to communicate in a way that's significant, meaningful, health literacy, understanding the degree to which people are able to understand and obtain the information to use it. This is huge. Plain language, understanding how to communicate, understanding how it's understood in the communities. This is where the example of sugar diabetes, understanding what the implications of that, how that word is used, and as a clinician, how we can make it more understandable so that the population from young to old in the African American community can understand more the disease and make the move to improve their overall health in a great way. Stereotypes, moving beyond this, where we have unconscious bias, where we have this implicit bias, That's huge. And I love the example of the iceberg again. Explicit bias is like the part that you could see above the water. That's the small little ice part that you see, but then you have the implicit bias that's under the water that you can't see, that's almost like the size of Texas, right? And so that's where you really have the significant problem, when you have these attitudes on race and gender, race, ethnicity, gender, socioeconomic status, health literacy, and you try to treat patients based on those unconscious bias thoughts. And so we have to certainly move beyond that, avoiding assumptions, having an awareness about common trends within a group, and explore patients' beliefs and values. And that's going to be huge. And then understanding cultural norms, the attitudes, behaviors that are considered typical or average for a social group, while beliefs are often referred to as values. So gathering information about cultural beliefs and health practices, asking questions, and, what do you call your illness? What name does it have? What does this mean? What do you think about treatment? What do you think about it? And I think about, as how I grew up, and diabetes again with sugar. And many people who were diabetic thought, oh, well, it's just I don't need to eat as many sweets. And they really didn't understand it was really about a lifestyle, and they didn't understand fasting blood sugar versus postprandial blood sugar, and understanding why exercise is important, and understanding what exercise do to manually help getting sugar or glucose into the cell so that it benefits the body. So we have to do more to make sure culturally we understand diabetes and understand disease. And then also cultural beliefs, beliefs about disease, approach to self-management, what it means to take medications. Why is, and that's why the conversation last time we had, I hope you understood oral medications versus injectable insulins or injectable GLP-1s or SGLT2s that are oral, the difference between those, so that you take that information, apply it to your cultural understanding, and hopefully that results in a greater effectiveness in terms of treatment. Okay. And then nonverbal communication, asking permission before touching a patient or direct eye contact, but understanding cultural implications of eye contact. Is this appropriate or non-appropriate? And being sensitive in certain areas. All of these are going to help us as we create equitable environments for patients to be in, and work to make sure that access is not an issue. And then open questioning. This is a part of the motivational interviewing techniques. What do you think? What do you think caused your diabetes? Why and when did it start? Do you understand what it means when we talk about modifiable risk factors and non-modifiable risk factors? What do you think diabetes does? How does it work? What are some of the challenges the illness has caused? What do you fear most about having it? What kind of treatment do you think you should receive, and what results do you hope to achieve from it? These are things that, from a questioning standpoint, that we're hoping we see more so in our communities to help take charge of the disease, to kind of turn it around. And then teach back approach. We covered a lot today. What can you tell me about what you understood? Is there one thing you can do this week to get started? Using that teach back approach, so that it shows that the person who received the information understood it and can then speak it back. And these are some of the things that we're trying to implement and encourage to be a part of turning this thing around. So emphasize the value of ensuring that everyone has an equal opportunity for health, and reducing disparities contributes to the common good for all. And then also, from a health messaging standpoint, diabetes, addressing potential distrust of healthcare professionals, the history of discrimination, religious practices, food preferences, physical activity, and how to talk about that, impact of poverty on engagement, self-monitoring, adherence with lifestyle and medical recommendations, and then clinical trial recruitment. And understand, just answering questions and understanding that all of those things are going to be huge to kind of make a difference. So this is all for today. I wanted to now kind of open it up. Rhonda, what any of your questions or any thoughts or anything from we had so far as we kind of go into questions now?
Thank you, Courtney. Yeah, there's only one question in the Q&A box. We can check and see what's in the chat box by chance, but I can respond to this one. The person wants to know about sessions 1 through 3. And if you go to YouTube and actually go to the California Black Health Network's YouTube channel, you'll see all of our webinars, not just the diabetes series, but all of them actually posted on the YouTube channel for CBHN. You can also get there through our website under the events and the archives tabs in the drop-down menu as a second option. And so I wanted to go back, Courtney, while we're waiting. Oh, let me check and see. Amber, are there any questions in the chat by chance?
No, there are not.
Okay, thank you. I wanted to kind of go back to a point that you made, which I think is really important. It relates to what you said about 80% of our health outcomes really relate to the social determinants of health, and how, you know, our zip code really dictates or determines life expectancy, right? We see that a lot here in California, as well as other parts of the country. But what I want to talk, well, actually both, but maybe a little bit more about that 30% that we can control, especially in the context of diabetes. And I know we're going to talk about prevention in the next session in a couple of weeks, but I think it's an important thing to note that, you know, because I often say health really happens outside of the four walls of any health center, any clinic, any hospital. So can we talk a little bit more about, you know, those factors that really impact that 80% and then the 30% that you talked about?
Absolutely. So you know, and I think you can't really talk about it enough. You know, when you think about 80%, 40% socioeconomic factors, right? So education. What we know is higher education tends to translate to better health, you know, because education really connects to the more you know, oh, then I should make smarter choices, right? Is it better for me to eat a bunch of fried food all the time, or to eat more fruits and vegetables versus fried foods? So therefore I'm like, I know that that's not good. But again, addressing a mentality sometimes that says, there's a reason why fast food is called fast food, right? Because there's a thought that fast food, because it's cheap and it's quick, that it's good, but it's not always good, because fried tends to connect more so to higher cholesterol and to more health issues. Employment, understanding employment's connection to health, understanding family and social support. It's been known that if a parent struggles with obesity, the kids tend to struggle with obesity. We know that when that happens, that contributes to a family that could possibly struggle from obesity. So, and then if the parents exercise or care about health, kids will be more likely to care about health as well. Income, the amount of, you know, being able to bring home income is a way that then connects to access to foods as well. And then community safety. Those are all the socioeconomic factors. 10% is the physical environment, just where you live. Now that's the smallest contributor, but then health behaviors, to your question, Rhonda, again, these are modifiable. You know, tobacco use, I can choose to smoke or not smoke, or, you know, being around that. Diet and exercise, I can choose to work out and exercise or not. Alcohol use, I can choose to drink or not, you know, and it's, you know, and certainly context is important, but, you know, alcohol within the context, we know some red wines are very, very, you know, important for cholesterol health, and they're actually good for you. But we're talking about alcohol use that is overly dependent can certainly put you in a bad situation. And sexual health certainly has a role to play in overall health as well. So when I look at these factors, I think about what's within my realm of control and what's not within my realm of control. And also, I think one of the elephants in the room is, you know, this whole thought process of eating healthier is more expensive. I think we have to really fight against that and work to find solutions where we can, you know, get that out of our mentality that, oh, to eat healthy is too expensive. We can't afford not to eat healthier. We can't afford to not focus on fruits and vegetables and incorporating greens and doing those things, because those are the things that are going to reduce inflammation and help us move towards being as healthy as possible.
Yeah, but what about in those situations where, say, if there's someone who does live in a community where they may not have, definitely not a Whole Foods or even a Trader Joe's, or it's mostly corner markets? Like, what do people do in those situations when we talk about access or getting access to healthy foods?
Yeah, it makes me think about one of my favorite times in Boys in the Hood, where uh, uh, Trey's father, takes him over in the place in Compton, shows him the neighborhood and shows him kind of, the dilapidated community, and kind of helps him understand, like, hey, it's been designed this way, and you really have to kind of recognize it for what it is and work to be smarter regardless of what's not there. And that's what I would say. We have to, as a community, be smarter. We have to figure out, okay, if I don't have the money for Trader Joe's or for Whole Foods, what do I have the money for? And what do I have within my realm of access? Is there a community farm? Is there do I have access to fruits and vegetables, good fruits and vegetables, through the local food bank or through some source to be able to get healthy foods? How do I cook them? I don't cook everything with grease. How about steaming vegetables and just doing everything that we can using our resources around us? Are there community-based cooking classes? That's what happened in Houston when they tried to give the community fresh fruits and vegetables, and they noticed that the people were throwing them away. They were taking the boxes of fruits and vegetables and throwing them away. And then they set up chef's class to tell them how to prepare eggplant, how to prepare squash. And that's when they begin to see, people taking the food and then using them. So I would say, Rhonda, we have to fight to, help them to move beyond excuses, to say, find areas where you can get those fruits and vegetables, understand how to prepare them, so that we all can move towards being as healthy as possible.
Yeah, totally agree. So we do have some questions in the Q&A box. And so someone wants to know that regarding culturally appropriate health education messaging for African Americans, have you found most diabetes report groups, group all Black and African Americans together? Yeah, so I guess instead of disaggregating, they aggregate them together. And do we even know what percentage of this large group are specifically Black people versus like people of African descent or Afro-Latino or Afro-Caribbean, right? That is the case, they're generally all grouped together.
Yeah, I think what they've tried to do is create where within the Hispanic population, they kind of try to break that down more so, whereas Black tends to be African American, those of African descent, which would include those who may have grown up in Africa, who moved here as adults, but they're still considered Black American. However, from a cultural standpoint, there are differences, because a lot of the struggle from an African American standpoint, those of us who were descendants of Jim Crow, in a sense, it's a little bit different. And obviously, I have great friends who are African, who've moved here and are not so much descendants of the Jim Crow as we are, who are African American. It's a totally different story, and we've had great conversations where I've worked to say, hey, you got to really understand the history of the African American here in the United States, and where the history and the struggle to understand why things are the way they are. And so I think that conversation is very valuable. But from a census standpoint and how it's collected, again, I think Black African American takes everybody in consideration. But I do think that there's subtle differences between all those who are descendants of the Jim Crow African versus those who may have moved here within the last 20 to 30, 40 years.
Yeah, and I know, data collection and data disaggregation is becoming more of a topic, especially as we're collecting information to really track and monitor what's happening with subpopulations of individuals. I see that now with the AAPI community. Like, I know sometime last year when I went to a doctor appointment, I noticed in filling in the intake form, there were several different options when you start to disaggregate the AAPI community. But I'm not seeing that as much with the Black community. And I think that data is important. But I also think there's somewhat of a reluctance to share data about who we are and some information about our health background because of the trust. But maybe you can talk to the importance of doing that and how that plays a role in really understanding or better understanding health disparities, in that process.
What's the question, Rhonda? I want to make sure I understand it before I say it.
There's a big push to collect data, right?
Oh yeah, like all of us.
Right.
Yeah.
Yeah. And so even when we go to the doctor and filling out the intake form, if they want to ask more information about your ethnic background, your health history, but sometimes I think there may be some people in our community who are a little reluctant to provide that information because we're not sure what's going to happen to it or what people are going to do with it because of, historical trust issues or mistrust. So I guess my question is, can you talk about the importance of really sharing that information and what role that plays in really better understanding health disparities?
Yeah, I think that's a very important point. I think, I mentioned the All of Us Research Initiative, which was sponsored by the NIH and National Institutes of Health. And what they're trying to do is gather research over 1 million individuals, minorities, and be able to have a warehouse of information to be able to understand disease, understand how to treat disease, understanding histories, connection to background, all of that being a part of it. I think that that's critically important. Now, the hurdle that we have to overcome from an African-American standpoint is the mistrust, the medical mistrust, the Tuskegee experiment, the Henrietta Lacks story, overcoming the thought process of almost like the inferior viewpoint, being inferior, they don't care about us. What Michael Jackson said, all I really know is they don't really care about us, right? So getting beyond that to say, okay, I gotta take my own health into my own hands and do something about it. And that's number one, understanding my genetics, my history, understanding, where I am, where my family is, and working to create good health that will benefit generations after me. So I think that that's what this is all about, and there's a reason why there's a predisposition for diabetes. And again, it has to do with diet. It has to do with genetics. It has to do with, the very complex history that is ours in this country. And when you think about what foods were made available, again, when W.E.B. Du Bois in 1896, he said it, it's the same, this is 100 years ago. It was the food that they had access to eat, where they would live, and the education. It was the same stuff that we're talking about now was the issue in 1896 and 1897. So I think that all of those are factors, Rhonda, and we have to think about building trust in the community. That means having the conversations here, answering the questions here, so that we can confidently move forward as a group and move towards being in better health, and then encouraging our families to do the same thing as well.
Okay, great. So there are a few questions in the Q&A box. So the first one is, have there been any studies done on the effects of prediabetes and type 2 diabetes as a pre-existing condition for COVID? Or, I guess more like an underlying condition for COVID, and how COVID has impacted folks with that in that situation?
Yeah. What we know is that diabetics, pre-diabetics, had a greater struggle with COVID. They struggled with COVID more so than those who were not diabetics, who were not. The people, what we know is that pre-diabetes is always linked to weight, being overweight and obesity. And I think it was the CDC came out in 2021. They found that there were greater hospitalizations, there were more people put on ventilators, and more people died who were overweight. Okay, it was over 70% of those, right? So we know that is significant. So when you're pre-diabetic and you're diabetic, when you get COVID, it's worse. It's harder on your body. And that's because the inflammatory cascade, you're going into COVID crisis that affects all the organ systems, the inflammatory process, and then ultimately it's showing up in breathing issues. So yeah, we definitely know that there was research done. In addition to that, there was this real strange kind of diabetes diagnosis that came up in individuals during the COVID time. And we've seen it where people just went to the doctor, no history, and they had diabetes. It kind of looked like type 2 diabetes. And so they talked about it, this type of diabetes that was kind of birthed out of COVID. So we haven't heard as much about it as of late, but that certainly was a part of the equation as well.
Great. Okay. And can you show how to navigate CBHN website to find the videos? Yeah, yes. So we will talk about that. So if you go to the website, you'll see a menu that says, or menu tab that says events. If you hover over that, there's a drop-down menu that says current events and some other events and archives. So you should be able to access our webinars that way, or again, maybe easier just to go directly to YouTube and search for the California Black Health Network. All of the videos from the webinars and other events are housed there. And then another question is, how much is peer and family pressure among Black populations to cook certain foods and eat certain foods a factor in diabetes? So
yeah, I think it's a big factor, especially if it's the encouragement to eat unhealthily, right? I mean, if it's, but I do want to say this, because my grandmother died at 99, right? And she made 2 cakes every other Sunday. She made a caramel cake. Y'all don't know about Miss Rhonda. You don't remember them caramel cakes, the old school caramel cakes, and a coconut cake, and would feed the preachers and stuff. I mean, we ate that way, but there was a lot of activity during the week. There was a lot of exercise. There was a lot of walking. There was a lot of working in the garden. There was a constant sense of movement. I think the problem now is you're looking at sedentary lifestyles plus eating high carbohydrate diets. So when you think about high carb diets, which predispose you to pre-diabetes or obesity or higher insulin resistance, that's where the problem comes into play, because higher insulin resistance aligning with obesity, then aligning to a diabetes diagnosis, that's where the problem is. So we have to help people get to a place where you're not eating as the high carb diets, that way. So that's what we have to sort of turn around and change, how the eating habits, are happening, and then also educating from a food standpoint and encouraging us towards fruits and vegetables without the gravy, steaming vegetables, steaming, healthy seasonings. And, I've worked with some good health coaches who really focus on that. How do you create more healthy foods? And there's some individuals who will do that, where they'll take you to Whole Foods. There's a gentleman, the health coach I work with here in the Dallas-Fort Worth area, Paul Ritter, phenomenal. He'll take you to Whole Foods, show you how to shop. A lot of people don't know how to shop, in a healthy way, and help you to move towards being healthier, incorporating more greens into your diet in a healthy way. And those are the things that we have to do to really kind of turn that around.
Okay. Yes. Generally, it's shopping the perimeter of any grocery store is the best approach, because there you'll find fresh produce and vegetables, and you can't get fresh. Frozen is best over can or any other type of packaged goods. And the second part to that question is, what are best practices for telling your family members that you don't want to eat hot links or chitlins all the time?
You know what? I mean, what I do, I just, hey, I don't do it anymore. I'm sorry, I don't do the pork rinds. I come from a family, they'll, homemade pork skins, get the pork skins, put them in the oven. I mean, I grew up in Arkansas, so yeah, all aspects of the pig were a part of our get-togethers, but you just cannot eat that way anymore, especially as you age. So I think you just say, hey, I can't eat like that. Can we make sure we steam some vegetables? Can we make sure that we can put some meats on the grill? I mean, you can do that in a way where everything doesn't have to be slathered and everything. Planning fish. I was at a family get together in California, and my one of my older cousins, he's in his 80s, Rhonda, and he made king salmon. He put it on the grill and it was excellent. So it's just really trying to be mindful and moving towards eating healthier, more fish, grilled instead of fried, the vegetables, doing those things, and, how we drink, drinking more water, instead of all of the sweet, Kool-Aid and, sugar just pour in the
Sweet tea,
bag.
unsweet tea. Talk about the South being the South.
Stopping that. Yeah, unsweet things, unsweet green tea, so just trying to make the decision and encouraging the family. That's how you raise awareness. You raise awareness by talking about it and being upfront about it, and looking at, I can't tell you, I'm close in my 50s, how many of my male cousins I've had to help because of blood pressure issues and just the health, many strokes, because of health practices in the 20s and 30s that led to them now in their 40s and 50s, having some health issues. So we have to begin to be vocal to turn this around.
Yeah, and I think there are some questions in the chat. Amber, can you, I think there's one question from someone very, very well. Amber, can you check the questions in the chat?
Sure, there are a few that have come in. I'm not sure that I'm starting with the person that you're referencing, Rhonda, but the first one from the top is just, can either of you speak to the type of research or programs currently going on, especially for minorities?
That's from Ms. Jessica.
Yeah, I know she's talking about all of us research by the National Institutes of Health. And again, that program is specifically focused on increasing minority participation in research. So, certainly something that you can Google, NIH, all of us research initiatives. And again, I want to say this, working for pharmaceutical companies over 20 years, one of my greatest frustrations is no matter what the disease is, when you typically look at the race breakdown in clinical trials, is 90% white, over 90% white in contributions. And guess what? Most clinical trials, you go and pursue the clinical trial. So I really want to encourage the African-American community, do not be afraid to reach out and do your own research about clinical trials, like to find out if there's a clinical trial relevant to you. And, sometimes, your medications will be paid for. But again, that goes back to trust. If we don't trust the establishment, we won't go and pursue that. But I'm just tired of seeing, even in diseases that are predominantly, like prostate cancer, where again, 60% of the cases are Black men, but the studies are 97% white. And that's because we don't pursue the opportunities to be in those studies. So we have to do our part from a research standpoint to participate. So all of us gives you an opportunity to give your data. And I would say 23andMe and Ancestry contribute to understanding your own history. I did 23andMe, family members have done Ancestry, and we found that extremely interesting to understand genetic makeup and background. Those things are going to help us move towards being as healthy as possible.
Yep. And the next question, Amber.
Yes, most people who have diabetes are heavier in weight. How is it that there are skinny people who have diabetes?
That's a great question. So you're right. The reason why heavier people tend to have diabetes, type 2 diabetes, is because more weight correlates with insulin resistance. When I'm heavier, I have more body. And insulin, when I eat my food and insulin is released, I don't have the same response to insulin because I have more body, and so therefore I don't use well the insulin that I do have, and I become resistant to it. Okay. And so that's where insulin resistance comes into play. And so losing weight helps you respond better to insulin. At the same time, I can experience beta cell burnout in the pancreas, which means my beta cells can't produce insulin the way I need in my body. So that's where the heavier. Now, individuals who are skinny, they can have type 1 diabetes where they have beta cell failure. It can be an autoimmune response where the body in itself works to destroy the beta cells in the pancreas, contributing to type 1 diabetes. And so they're smaller. But then there's also some smaller people from a genetic predisposition who are type 2 diabetics as well because of their genetics. So all of those things can work into play, but to know for sure, that's why you go understand what your A1C is, understand what your blood glucose levels are, and that'll basically tell you. But that's a great question.
Okay, are there other questions, Amber, in the chat?
One last one for you, Rhonda. What can residents do to ensure funding for CBHN?
What can residents do to ensure funding for CBHN? Well, we welcome donations from everyone. There's a way to donate on the CBHN website. So if you go to the website, you'll see donate. There's also a left sidebar menu that pops out for other options to support the organization. So you can volunteer, you can become a member. You know, donating is always welcome. So whether it's a small incremental donation that people want to tithe on a regular basis to the organization, or we accept any form of contribution and support that people are able to provide. So thank you for that question. I guess that's the last question. Just want to give you an opportunity, Courtney, to kind of leave us with some key learnings or lessons to take away from the conversation today.
Absolutely. I want to go back to my statement on if a flower doesn't bloom, you fix the environment in which it grows, not the flower. I love that example. I grew up where my grandmother raised all types of flowers. Elephant plants and flowers were everywhere. And when I was a kid, I really didn't have as much of an appreciation for what it took to take care of a flower and plants. But I knew periodically I had to go get the pitcher of water and go water her plants and go water her flowers outside. It was about taking care of them, right? And the better job that I did, the more they flourished and the more they grew. And the same is true for a person. When we make sure that people are able to get the resources that they need, then they're able to move towards being as healthy as possible. And that's resources, that's foods, that's water, that's education, all those different things, those different elements that work to make sure that they can be everything that they can be and can become is critically important. And I think now we're aware of the disparities between the resources in different people groups, and this is an effort to do something about it. So I just want to encourage everyone watching that you can contribute to ensure that the next generations are as healthy as possible, and existing generations can make changes to move towards being as healthy as possible. It's critically important. And organizations like CBHN are focused on making sure access is focused on, and there's something being done to improve access within the African American community, and to ensure that the resources are where they need to be as well. So thank you guys so much for these 4 sessions. We got one more to go, but this has been a joy, and I hope, you know, it's given all of us something to think about so that we can move towards a healthier African American as it relates to diabetes, and as it relates to the state of California.
Yeah, thank you, Courtney. And I think all that you spoke to kind of is related to self-care, right, and taking better control or greater control in charge of our lives. But there is one more question that I think might be important to address in that context. And the person wants to know how do other weight loss measures other than exercise such as weight loss surgery, affect the body's use of insulin, if at all?
Yeah, it depends. And so that's something that, there are different methods of weight loss surgery. So you have to take in consideration if it's a gastric bypass, it seems to affect how insulin and diabetes medications are used. So they have to kind of look to see, because we have seen responses from those who've had gastric bypass. That's something that they've had to adjust when it's a gastric sleeve, or it's not as harsh, but that gastric bypass can be pretty intense. So those things you have to be aware, do it in concert with your physician, your bariatric surgeon, your endocrinologist, so that they can know how your body is responding after surgery, because it can affect your how your body uses insulin, how your body responds to medications. Yeah, because you have had cases where people have had these procedures and then they regain the weight, and then they end up having to get on anti-obesity medications. So all of those things have to come into play, anti-obesity medications, but also their diabetes is not managed as well. They lose a whole bunch of weight, but you just have to be under the care of an endocrinologist to figure out exactly where you are.
Okay, great. Thank you. So thank you so much, Courtney. The time always flies when we're with you. You always share a wealth of information and knowledge, and we really appreciate that. So just to wrap up the conversation for today, you can connect with CBHN. You can join us in support of the Campaign for Black Health Equity, which is our major fundraising initiative to invest in some of the key activities like the event today, to help educate our community about some of the things that we've talked about. You can follow us on social. Most of our social is on Facebook, Instagram, and Twitter. You can just go to your CBHN, and then on LinkedIn, we're California Black Health Network. Just a couple of upcoming events. Courtney talked about the next time, which is June 15th at 12 p.m., which is the 5th and final session in this series, and it's focused on diabetes prevention and how to control the controllable. So what are the things that are within your control that you can really focus on to minimize your risk of diabetes, or if you think you're predisposed to prediabetes or have prediabetes, what do you do to control so it doesn't escalate into the full-blown disease? And then also we have two events coming up, one on June 10th and one on June 24th as part of our Black Beauty Project. So we'll be at the KJLH Women's Health Expo on June 10th, and we are hosting a session on Black women, hair care, and our health. We'll also be in the exhibitor hall. On June 24th, we are hosting the Better Black Beauty Ambassador Training events or program at Faithful Central Baptist Church in the living room space. And so that is in Inglewood, and that event will be in virtual, it'll be in person as well as virtual. So the registration is available on our events webpage on the CBHN website. And just want to thank you all for being here today. For those of you who have consistently participated, thank you for your commitment to the program, and hope to see you on June 15th. Thanks, and have a great afternoon.